All right, my name is David Cohen. I'm an internal medicine physician at the Lycanor Medical Center. I do both inpatient and outpatient medicine, and I have a passion for teaching, and close to every day I am involved with dissecting medical cases and giving medical lectures. This is going to be my first YouTube video. Okay, and I am going to talk this morning about a topic that my medical team, consisting of a resident, an intern, and 2 medical students, wish for me to discuss, and that topic is thrombocytopenia. So I'm going to give a basic short talk on thrombocytopenia. Thrombocytopenia, theoretically, your platelet count's under 150,000. And this certainly is not an uncommon medical problem that we see in the hospital. So you need an approach to thrombocytopenia. And I need another marker. So here are some important numbers. That's number one. If your platelet count is under 50,000, you run the risk of bleeding with the procedure. If your platelet count is between 10 and 20,000, you could bleed spontaneously. You need at least 7,000 platelets to form a clot. So if your platelet count is under 7,000, you're in a lot of trouble. And it's important really to understand these numbers. So if a patient is thrombocytopenic, you need to determine the etiology of it. And before you go on a journey to determine the etiology, okay, you need to rule out an entity called pseudothrombocytopenia. And this is due to platelet clumping. So sometimes the lab tech will report a lot of platelet clumping. If not, you may have to look at it yourself. But normally when you're looking at a peripheral smear, each little platelet here represents about 7,000 to 10,000 platelets. And if you see a bunch of these all clumped together, you may have pseudothrombocytopenia. And that's an abnormal reaction to EDTA in the lab tube. And you would have to get a CBC with a platelet count, obviously, in a black top tube where they use citrate there. But this you want to rule out. Now, let's assume the patient doesn't have thrombocytopenia. So you have to figure out what it's due to, and there are really a myriad of things that could cause it. The first thing you want to know is really a patient history. Do they have a history of thrombocytopenia, or do they acquire it while they're in the hospital? And they're big etiologies. Or they could have had normal platelets to begin with, come into the hospital in the emergency room when they're being admitted, they're thrombocytopenic, and that persists. Or they could come into the hospital and their platelet count is normal, excuse me, and they become thrombocytopenic. So the 3 major mechanisms are a bone marrow problem. The bone marrow is not making platelets, increased platelet destruction, or splenic sequestration. So it would make sense to rule out splenic sequestration first, okay? And you could start with physical exams, seeing if you could palpate a spleen or percuss dullness in Travi space. This you could often miss. And we don't automatically image the patient's spleen in the evaluation of thrombocytopenia. But if they have a cause for splenomegaly, such as cirrhosis with portal hypertension, or a lymphoproliferative neoplasm like non-Hodgkin's lymphoma or CLL, then we may consider this. As far as a bone marrow problem, often it affects all cell lines. And you can see pancytopenia. And, any hematologic condition, such as one of the myelodysplastic syndromes or acute myelogenous leukemia, or other things that infiltrate the bone marrow, you would have to think of that. You can see this with the megaloblastic anemias like pernicious anemia. Although it's not common, folate deficiency. There are a slew of things, and there are also medications that can involve the bone marrow. Most commonly chemotherapy. So if you have a patient who's receiving chemotherapy and the thrombocytopenia, you have to assume it's due to that. And then you have peripheral destruction of platelets. And you could break that into two causes: immune thrombocytopenia and non-immune thrombocytopenia. So immune thrombocytopenia, the classic condition that does this is ITP, where you have antibodies that are produced that are bound to the platelets. They're felt to be abnormal, the platelets, and they're sequestered by macrophages in the reticuloendothelial cells, such as the spleen and the liver. You can have ITP due to secondary conditions also, such as lymphoproliferative diseases, lymphomas, both non-Hodgkin's and Hodgkin's, and CLL. You could see it with autoimmune diseases, the most common being lupus, which we cause this. You could also see certain infections that cause ITP-like pictures, HIV, hepatitis C, and Helicobacter could also do this. There are medications that could cause autoimmune ITP-like syndrome. And there are other conditions that they've also reported that could have associated immune-mediated thrombocytopenia. Something else that this is a different type of immune-type thrombocytopenia, the condition known as HIT, or heparin-induced thrombocytopenia. Sometimes it's called HITT, heparin-induced thrombosis with thrombocytopenia. And with this, these people do not bleed, and they really do not have super low platelet counts. You worry about thrombosis, venous, arterial, or both. And you could have this is one of the most thrombophilic, one of the most catastrophic hypercoagulable states you could have. And to assess this, there are different ways, but one thing is called a 4T score, where you have thrombosis, thrombocytopenia, timing, which is 5 to 10 days within getting the heparin or low molecular weight heparin, and ruling out other causes of thrombocytopenia. But if somebody, you could also see it with low molecular weight heparin, but it's more common with heparin, and this is something you want to rule out. And another immune cause that doesn't cause bleeding that could cause thrombosis is paroxysmal nocturnal hemoglobinuria, and that's a little too esoteric for this talk. Abnormal sensitivity of the cell lines to complement. Then there are the non-immune thrombocytopenias, and basically in here you have the thrombotic microangiopathies. The big three are TTP, hemolytic uremic syndrome, and DIC. We will see these during the course of the year, especially TTP, which is abnormal atom TS13, the level's low, and you can't inhibit von Willebrand's factor. These conditions are associated with a MAHA, microangiopathic hemolytic anemia. With them, you're going to see thrombocytes. You're going to see schistocytes. You're going to see schistocytes in the peripheral smear, thrombocytopenia, and often involves the kidneys. And classically, with TTP, there's a pentad. You could also see CNS changes and fever, and you certainly don't need all of them. Hemolytic uremia comes in two flavors. The classic one follows a GI illness, with something associated with Shiga toxin. Classically, you have E. coli 0157H7. You can see it with other GI infections. So if somebody has the triad, thrombocytopenia, microangiopathic, hemolytic anemia, and renal dysfunction, and they had prior GI infection, you have to think of that. And then there's a congenital form associated with abnormalities of the alternate complement pathway. And they're a new group of diseases that could do that. DIC, there's a coagulopathy also, and there's usually a condition precipitating DIC, and that's usually sepsis. You could also see it with certain cancers or obstetric complications. Going back here, you could also see a post-transfusion reaction related to blood transfusion, where you could get immune thrombocytopenia. Another infection that you would think of, Epstein-Barr virus or mono, could do this. And there's certain medications, especially antibiotics, you have to think of causing immune-related thrombocytopenia. The classic ones, vancomycin, nafcillin could also do this, linezolid, and there are other antibiotics that could do it. And then there are other medications that have been reported to cause both destruction and marrow problems. Medications such as H2 blockers, rarely PPIs and other medicines, but oftentimes a patient comes into the hospital, becomes thrombocytopenic, and we're not sure why. Also, you can see thrombocytopenia immunologically related to sepsis without DIC. So you can just have thrombocytopenia and no DIC with sepsis. So this is kind of a pathway to approach thrombocytopenia. The conditions that cause very low platelets, under 10,000, there are really only three. The thrombotic microangiopathies, immune-mediated thrombocytopenia, and medications. Those are really the conditions that cause very, very low platelet counts. With HIT, and you have to worry about that with patients, that, you're going to have platelet counts around 50,000. You're not going to see a platelet count of around 6,000. This is just an approach to thrombocytopenia. Obviously, once you find the cause, you have to treat it. If there's an offending medicine, you have to stop it. If it's immune-mediated initially, you're going to try corticosteroids, and if that doesn't work, immune globulin. If you think it's a thrombotic microangiopathy, then you're going to have to consider plasmapheresis. DIC, you want to treat the underlying cause. And then if you have heparin-induced thrombocytopenia, you'd possibly give argatroban, or there's some data now that you could use DOACs for these patients, or fondaparinux. And with that, I'm going to stop. Hopefully this was helpful, and this is my first YouTube video I'm making regarding medical education, and once again, the topic is thrombocytopenia.